Thanks for joining us tonight. We're just waiting for everybody to make their way into the call, so we'll just give it a few seconds and then we will get started. And see our numbers still going up while everybody joins. Hope everybody's having a nice evening. We had a bit of sun here tonight, so that's quite nice. Okay, I think we've pretty much got everyone in. I'm sure we'll have a few extra people join in the next few minutes, but let's get started. So thank you all for joining us this evening. I am Claire, and I work for the Birmingham Biomedical Research Centre. And I'm here today to facilitate the talk with our expert, Professor Simon Jones, who I'll hand over to in a few minutes. But first of all, just wanted to say that we're delighted to see you all here this evening to join us for our series of easy to understand online talks about health research being carried out at the NIHR Birmingham Biomedical Research Centre. Today's talk specifically will focus on obesity and osteoarthritis. But there are many other talks that we have delivered, and we've got a few more to come covering different health conditions over the coming months. Before we get started, I just wanted to give you a little bit of information about what the Biomedical Research Centre is. We are a collaboration between universities and the NHS. And we're managed by University Hospitals Birmingham NHS Foundation Trust in partnership with the University of Birmingham and along with some other partners which you can see on the screen here. We are publicly funded by the National Institute for Health and Care Research, which is the NIHR acronym that you'll see in our name. And that is part of it's kind of the research arm of the NHS. And we're not the only BRC. There are 20 BRCs like us across England, all working to improve people's health. At our research centre, we have doctors, nurses and other healthcare staff that work together with researchers to take new scientific discoveries found in science labs and turn those into diagnostics, which is like tests or procedures which can help to identify an illness or an injury, and treatments. And our research specifically focuses on the causes, effects and treatment of inflammation. Now, inflammation is a word a lot of people will be familiar with, and it's a normal part of the healing process. And we've probably all experienced it at some point in our lives as either pain or swelling, heat, or loss of function or movement, for example. But sometimes the body overreacts, and too much inflammation can cause further problems and is linked to a number of health conditions such as arthritis, infectious diseases, diabetes, and cancer. Just to let you know that we would like to hear from you tonight. If you've got any questions that you would like to put to Simon Jones, if you want to do that, you can use the Q&A function, which is potentially at the bottom of your screen. Sometimes people's screen layouts are slightly different, but if you look for the Q&A box like the icon you can see on the screen there, you'll be able to ask your questions, and we will try and answer those at the end. Just a quick reminder that we are not able to offer any medical advice tonight, so we won't be able to answer any questions like that, unfortunately. But as I say, we'll cover as many questions as you can at the end. The webinar is being recorded, and we'll share the recording of this after the talk, so you'll be able to watch it back or share it with others who perhaps couldn't attend today. So, on that note, I'm going to hand over to Professor Simon Jones to kick off with tonight's presentation. Over to you, Simon.
Right, thanks, Claire, and welcome everyone. Good evening. So we're going to look at some of the evidence behind the weight loss drugs, some of the clinical data that might suggest this will help people, not just those with obesity, but also people with osteoarthritis and obesity. Before I get going, I'm just going to talk a little bit about the theme of our BRC. As Claire mentioned, we're a biomedical research centre. And we're focused on inflammation, but we have a particular theme called sarcopenia multimorbidity. And here we're looking at understanding how muscle, skeletal muscle mass and function declines with age, and how that is worse when we have inflammatory disorders. We're also interested in aging of the joint, that's osteoarthritis, and that's the focus we'll talk about tonight, and understanding how obesity contributes to the onset and progression of osteoarthritis. Ultimately, what we want to do, of course, is take that understanding and learn how we can develop new treatment strategies, even including repurposing existing drugs to these conditions. So what is osteoarthritis? Well, it's the most common age-related joint disorder. It affects around 25% of people over age 50. Now, many people perhaps don't know they've got osteoarthritis until they go to the doctors, and maybe they have some reduced joint mobility. They might have some discomfort. Sometimes they report having weakness in the leg and in the muscles of the joint. And it's only upon an X-ray radiograph of the joint that will be diagnosed with osteoarthritis. It's common to find it in the knee, hip, neck and spine, hand, and also the big toe, often confused and misdiagnosed as gout in the early stages. So it's unusual in that it's not all joints affected, it's particular joint sites where we tend to see osteoarthritis. When the X-ray is undertaken, what the clinician is looking for is a couple of things on there. One is that the joint space has got narrower, and you see also a loss of cartilage on the X-ray. And if you look at this picture, the radiograph on the right-hand side, this is the knee joint. We've got a healthy knee joint on the left, and on the right, there's a knee with osteoarthritis. And hopefully you can see the patient with the knee OA, that joint space that separates the two bones has become narrower. And there's also a loss of the cartilage that cushions the joint, and it forms the end of the bones and makes the joint protective in terms of load applied to the joint. Now, we also know with osteoarthritis, it's not just about joint space being narrowed and the loss of cartilage, but we also see changes to the bone. And often that can be seen visibly in the finger nodes, where you get these little nodules that form, and that tells us that there's abnormal bone remodeling occurring. And these bony spurs, we refer to these as osteophytes. Now, one of the things we know about osteoarthritis, we've known this for a long time, is this increased risk of developing osteoarthritis with obesity. So on average, people with obesity are between 3 and 5 times more at risk of developing osteoarthritis. And when patients progress with the disease and then need a joint replacement, most people we see having a joint replaced are either with obesity or are overweight. So that risk is quite clear. And for that reason, one of the obvious strategies then is, well, what about if we lose weight? If we lose weight, well, can we improve the signs and symptoms of osteoarthritis? So that has been looked at. There's been lots of studies looked at different weight loss diets, and sometimes combining those diets with physical activity. The idea being, if we lose the weight, will we reduce the load in the joint and in turn then improve the signs and symptoms of osteoarthritis? And quite a few studies have shown that's quite effective. We have seen improvements in joint pain and even improvements in function in patients with knee OA who've had obesity and lost that weight. For every pound of weight that's lost, the load that's applied to the joint is reduced by about 4 pounds. That's about 1.8 kilograms. How much do you need to lose to see real effects in the signs and symptoms of osteoarthritis? Well, unfortunately, the more the better. So 10% weight loss has been shown to be better than 5%, and 20% has been shown to be better than 10% weight loss. So that's quite a significant amount of weight loss. And of course, one of the problems with diet and also physical activity, particularly in elderly people, is can that be maintained? And often we see that the weight will come back on most diets. Maintaining the weight loss has been proved to be very, very difficult. And of course, that brings on to the weight loss drugs that we're hearing so much about. Can these then do that job instead of the diet and physical activity? So there's a number of these. You may have heard some of the names of these, and some patients may already be taking some of these drugs, being prescribed drugs for being overweight or with obesity. I've put some of the names on here. Mounjaro is made by a company called Eli Lilly. And there's a couple on here made by a company called Novo Nordisk. Wegovy, Saxenda. And the way they work is they're designed to mimic naturally occurring hormones that we all have called incretins. And there's a couple of these, one's called GLP-1 and the other's called GIP. And what we know is they have different effects on different organs in the body. So these drugs affect the brain. They make us feel less hungry. They give us a feeling of fullness. They also have a little effect on the heart. So they slightly increase our heart rate and circulation. And they also affect the pancreas. So they boost insulin secretion. That allows us to improve our sugar control. So an effect there clearly on perhaps helping with diabetes as well. They also affect the stomach. So they reduce the digestion process. So it makes us feel fuller for longer. And some evidence that they may directly affect the cells in the adipose tissue and our fat tissue, increasing the utilization of fat when it's stored in the fat tissue. So I'm just going to show you some of the clinical data behind these drugs. So this study was with patients who were either overweight or with obesity. They were healthy otherwise. 304 of these were in the study. 152, so half of them, got the weight loss drug, Wegovy, and the other half received the placebo. Both of these groups, what's important to know is both groups were following a diet deficit, so about 500 calories less per day, and also receiving some advice around physical activity levels with the objective to achieve 150 minutes of physical activity per week. So the data on this looks like this. So this graph shows you the percentage change in body weight over time. The study was run for 2 years. And you can see, if you look first of all, the placebo, so this is the gray line. So these are the individuals only following the diet and the physical activity advice. And you can see over time, they've lost some weight. So they've lost about sort of 3% of their body weight. And it's maintained fairly well, perhaps creeping up a little bit out to 2 years when we get to 104 weeks. But look at the huge effect now compared to the weight loss drug semaglutide. We're seeing a much more dramatic loss in body weight to around about 15% decline at 68 weeks. And then importantly, that's maintained. And these individuals, not only did they lose weight, but we also saw improvements in blood pressure, improvements in sugar control, so reducing risk of type 2 diabetes, and improvements in cholesterol levels as well. So really fantastic effects of this drug in patients with overweight or obesity. So because of that weight loss reduction, we're now seeing a lot of information that suggests these improvements in diabetes control being one because of that better sugar control, the cardiovascular protection because of the improvements in cholesterol levels. We're also seeing evidence that they may improve kidney health, liver health, and also sleep apnea. So you may have seen some of these headlines according to these drugs, these weight loss wonder drugs, redefining how our bodies work, transforming healthcare, driving a healthcare revolution. But there's a few things that perhaps we would say aren't typical outcome measures for clinical trials. So this is a data that says that actually might improve your libido if you take these drugs. So quotes from some individuals here: my dating app matches have tripled since taking a weight loss drug, and my partner jokes have now become a sex machine. So some, I'd say, non-typical clinical outcome measures being reported. There may also be some adverse side effects with these drugs, with people reporting that you may find your toxic ex comes back into the picture. Since I started semaglutide, my ex texted me out of nowhere. So not perhaps a desirable effect there, but joking aside, clearly these drugs are having plenty of beneficial effects, maybe building up people's confidence again and improving the day-to-day quality of life. So what about osteoarthritis? Is there any evidence then that these weight loss drugs can improve the signs and symptoms of patients with osteoarthritis? So let's have a look at that. So this is a clinical trial. I'm going to show you two clinical trials. This first one involved patients with knee osteoarthritis with obesity. There were 407 who entered the trial. 271 received the weight loss drug Wegovy, and 136 received placebo. And again, similar to the other study I showed you, both groups received some dietary advice and reduction in calorie intake, and again, advice around improving physical activity levels. So we looked first of all at reduced body weight. It's a very, very similar picture to the previous clinical trial data. Again, we see this little bit of reduction with placebo. So it's around 3% reduction in body weight, and this was maintained up to 68 weeks. But again, with the weight loss drug, we're seeing much more of a marked decrease in body weight. So again, it's about a 15% reduction in body weight out to 68 weeks. So that's the weight loss. What about signs and symptoms of osteoarthritis? Well, in this study, what they measured was joint pain, and they measured this on a scale we call WOMAC, and they measure pain whilst performing different activities, such as standing, walking, sitting, and lying down. And they add up this score, and they give you an overall pain score. So on this graph here, we're measuring the change in pain score, and again, it's over time on the x-axis. Placebo, we see those that follow the dietary advice and physical activity improvements, they did see a reduction in pain score. That's fantastic, just through lifestyle interventions, showing that we actually can improve pain in patients with knee osteoarthritis. But importantly, what we're also seeing is with the weight loss drug, we're seeing again a significant decline beyond what we see with placebo. So much more marked decrease in pain score in patients taking the weight loss drug. Second study I'm going to show you is what we call a retrospective study. This is when we look back at data. So we haven't planned this study, but we've gone back through medical records to see if there's any evidence that patients who have been on weight loss drugs may over time have developed or progressed less quickly with their osteoarthritis. So these groups of patients, there were 1,455 patients with knee osteoarthritis in this study. 188 of these were patients who had been taking a weight loss drug for a period of 5 years, and they compared these to those who had never taken a weight loss drug. And they looked at the medical records using MRI to measure the amount of cartilage that was in the joint and to see how that changed over the 5-year period in these two patient populations. So looking first at those that had never taken the weight loss drug, over 5 years, as expected, the osteoarthritis developed, and the joint showed significant cartilage loss over those 5 years. Comparing those to the patients who had taken the weight loss drugs over that same period, these patients had reduced cartilage volume loss. So they still lost a bit, but the amount they'd lost was significantly less than those patients who had never taken these weight loss drugs. So what's the mechanism of this? Why are we seeing that improvements in joint pain, and perhaps also in that last study seeing that the weight loss drug slowing the amount of cartilage loss over time? Well, it's quite likely that some of that effect is an indirect effect of losing weight. So we take the weight loss drug, we lose the weight, and we would then expect less load, less stress on the joint, and perhaps that then causes the joint to be damaged less quickly. So it causes some protection, and patients feel improved pain, and we see reduced loss of cartilage over time. So that would be indirect. It's not directly affecting the joint, it's reducing weight, and in turn, that's reducing stress and load on the joint, improving signs and symptoms of the knee osteoarthritis. So that, I think that's probably certainly part of the story. But what's interesting is when we look at this connection between obesity and osteoarthritis, that increased risk of osteoarthritis, we see that increased risk not just in the knee and the hip of patients, but we also see that increased risk of developing osteoarthritis in the hands. But hands are a non-load-bearing joint. So that tells us that this connection between obesity and osteoarthritis isn't just about load in the joint. There's something else going on that's causing obesity to increase the risk of developing osteoarthritis. So why does obesity increase the risk of developing osteoarthritis in the hand? So we're going to look at answering that question now. And the answer lies in the fact that we now understand that osteoarthritis is not just a wear and tear disease of the joint. So many years ago, when I first started working on osteoarthritis, we all referred to it as a wear and tear disease There wasn't much that could be done about it. We're just going to damage our joints over time as we use them. And that's not the case at all. What's really clear now is that a key feature of the disease is what we call inflammation. Claire mentioned this inflammation at the start. Inflammation is, we used inflammation in terms of if you get stung by a bee or an insect bite. But what we're talking about here is chronic inflammation that is sustained over a long period of time, and that can be quite damaging. What we find in osteoarthritis patients is the lining of the joint becomes inflamed, so it becomes inflammatory, and we call that synovitis. And you can see on the right-hand side, this is an MRI scan from a patient with knee osteoarthritis. So we've got the two bones here, the femur and the tibia bone of the knee joint. And hopefully you can see on the MRI scanning these very, very white spots, these white patterns. And that's evidence of synovitis, it's inflammation around the knee joint, around the joint lining of a patient with knee osteoarthritis. And what's important is that that inflammation occurs early in the disease process. So we can measure that. We can use the MRI scans to assess whether the patient has mild inflammation, moderate or severe. And this graph is comparing the two populations, comparing patients with knee osteoarthritis in the very early stages of the disease before they have really clear evidence of cartilage loss. So there won't be much damage of cartilage in these patients. And then we're comparing those to patients we call end stage. That's when patients will undergo a joint replacement for their osteoarthritis. And what we've done on this graph is we've color-coded the severity of the inflammation. So the dark red is where they have severe amounts of inflammation. And then we've got a pinky color, which is moderate, and then a very pale pink, which is mild inflammation. You can see when we get to the end stage disease, almost all patients have very severe inflammation in the joint. So lots of those are red, and the rest of them are the sort of dark pink. But what's important here is look at the early stage patients who have just been diagnosed with osteoarthritis. Even in these patients, we're seeing half of them have pretty severe inflammation, and the other half mostly have moderate, and only a few have mild inflammation. So when we see this pattern, it tells us when something occurs very early in disease, this might be a driving factor, it might be a causative factor, but this inflammation then happens before we then see clear signs of cartilage damage. So what we know about this inflammation that occurs is when the joint becomes inflamed, that joint lining becomes inflammatory, that causes a release of inflammatory molecules that then enter the joint space. And those inflammatory molecules can promote the loss of cartilage, it causes the cartilage to be degraded. And importantly, also sensitize nerve endings. So the joints infiltrated with nerves, and those endings, when they encounter these inflammatory molecules, become sensitized. And a sensitive nerve then, of course, is what we then perceive as a pain signal to the brain. So the joint will become painful because of the inflammation sensitizing those nerve endings. In one of our studies, we tried to look at how closely is this connection between inflammation and where patients tell us that the joint is painful. So in this study in patients with knee OA, we asked patients, could they mark on a crosshair of the joint, where did they feel pain, and were there areas that they didn't feel any pain at all, or perhaps less pain? And then we used MRI to map sites of inflammation around the knee joint to see, was pain occurring where there was great inflammation? And the answer was, it was the case that where patients told us the joint was painful, in each of those locations, we were seeing there was greater inflammation at that site. So there's a really strong connection between where the joint is painful and actually that what's happening in terms of pathology of the joint, in terms of being more inflammatory at those sites. What we also know from our research is an understanding now of what's really causing that inflammation, and we've identified the cells that regulate that process. So in the joint lining, there's a cell type called a synovial fibroblast, and this cell works with the immune cells that are present in that environment to regulate the inflammatory response. So it's a key cell type in controlling how much inflammation will occur in the joint, whether it's a high amount of inflammation or a low amount of inflammation. And what we've found is the inflammatory activity of the cell type is increased in patients with obesity. So the graph on the right-hand side is measuring the amount of inflammatory activity of the synovial fibroblast cells in the joint lining. And I'll just talk you through this slowly. In the white bar is this patients without osteoarthritis and who have normal weight BMI. So that what we see in these individuals is quite a low level of inflammatory activity of these cells. If we compare these to patients with hip osteoarthritis with normal weight, you can see a little bit of an increase now. These cells are more inflammatory with osteoarthritis disease. But the big story is the black bar on the right-hand side. These are patients with hip osteoarthritis, but also with obesity. And we see that these cells become a lot more inflammatory with the combination of osteoarthritis and obesity. So that's quite interesting. But of course, this is hip osteoarthritis, and we know that hip is a low-bearing joint. So it is possible still that from this data, it could be that with hip osteoarthritis, it's the load on the joint with obesity being increased that's making these cells more inflammatory. So to answer that question, was it just about load still or something else going on? We found another study, which we called hips, hands, knees and toes. And for this study, we recruited patients either with osteoarthritis in the hands or the foot or the knee or the hip. So these are, importantly, have different load bearing. So we know the hand is not a load bearing joint. The foot is a little bit more load bearing. The knee is more load bearing still. And the hip is the most load bearing of these four joints. And we looked at patients in these four groups who were either of normal weight or with obesity. And we looked at the inflammatory activity of those fibroblast cells in the joint lining. So the first bit of data on this is to show you, again, the inflammatory activity of these cells across the different joint sites. And what hopefully you can see is no real difference in activity of these cells, whether they're from the hand, toe, knee, or hip. So what we can say from this is that the amount of load bearing on the joint is not directly making these cells more inflammatory. But if we then group them in terms of the obesity versus normal weight, we see what we saw before, that obesity makes the cells more inflammatory. And this is true from the hip, knee, foot, and also the non-load bearing hand joints. So it's obesity that's the driving factor in making these cells more inflammatory and more active. So in which case, is it possible that these weight loss drugs could improve hand osteoarthritis in patients with obesity? And secondly, is it also possible that these drugs might directly affect the cells in the joint? We saw before that the proposed mechanism was that there was an indirect effect. Patients lose weight, and that in turn may reduce load in the joint, and we see improved signs and symptoms of osteoarthritis. But could it be possible they also directly affect the activity of the cells, improve the cells directly in the joint? So to answer that question, we started a new study in Birmingham. It will run for 2 years, and we're working with one of the companies, Eli Lilly, that makes some of these weight loss drugs. And we're taking cells, cartilage from the joint and also the joint line tissue, and isolating the cartilage cells called the chondrocytes, and also isolating the fibroblasts from the joint lining again, and then directly treating each of these cells with the weight loss drugs. And we're testing different weight loss drugs to examine, firstly, will they make the cells less inflammatory, and will they make the cartilage cells, the chondrocytes, produce stronger and better cartilage? Now, we haven't started a study for long, but I'm going to show you a snippet of data that's already come out, which is looking very, very promising indeed, where it shows that if we treat the cells directly with these drugs, we see a reduction in factors that would promote cartilage degradation. So you can see here in this graph here, we've got untreated cells of the blue dots, and in the red, we've got cells treated with the weight loss drug, and we're seeing a reduction in factors that would promote cartilage loss. Now, this also, I think, raises an interesting question, which we don't have the answer for at the moment, which is if these drugs directly affect the cells, will they also be beneficial for patients with OA, even in those patients who don't have obesity or aren't overweight? So that's an intriguing question and one we hope to be looking at in the near future. So just to summarize, just the key points really from today, we see this risk of obesity both in load-bearing joints such as the knees and hips, but importantly, we also see that risk in non-load-bearing joints, so the hands. And that's because we now understand that OA is not just a wear and tear disease, it's a disease of inflammation. The joint line becomes inflamed, and that promotes cartilage loss and drives joint pain. And that's down to the activity of these cells called synovial fibroblasts. And what we've shown is that these cells are more inflammatory with obesity, irrespective of which joint site they've come from. If we look at the clinical studies, we're seeing really promising data coming out that these drugs are reducing joint pain in patients and also slowing loss of cartilage over time in knee osteoarthritis. And our emerging data may suggest we see direct effects of these drugs on the cells of the joint by reducing factors that will promote cartilage loss and maybe also calming inflammation in those joint cells, in which case will they also be beneficial for other patients with osteoarthritis who are of normal weight. And with that, I'd just like to say thank you very much and happy to take questions.
Thank you, Simon. We'll just have a quick look at the questions and see what's been coming in. I know we've had a few so far, so let's have a little look. If anybody would like to put a question in, it's not too late, so do just put your question into the Q&A function and we'll see how many we can get through. Right. So we have one question here. It says, given that many osteoarthritis patients may be older or have comorbidities, are there specific safety concerns you consider when prescribing these drugs in that group?
There are. I mean, if you look at the clinical trial data, certainly there's evidence in those clinical trials of increased gastrointestinal side effects. So could it be heartburn, could be diarrhea symptoms. So there are evidences that there's some adverse effects there, to a great extent than in the placebo. I think that would be true of almost all drugs. I think at the moment the data would suggest in patients with overweight or with obesity would benefit from the drugs. But it's something to certainly talk to your clinician about in terms of any other comorbidities that maybe need to be considered before being prescribed the drugs, for sure.
Okay, thank you. Another one, if it's not that load bearing increases inflammation, but obesity does, what is it about obesity that causes the inflammation?
I mean, that comes down to the activity of those cells. So what we know with obesity is that obesity changes the adipose tissue. So the fat tissue changes into a more inflammatory tissue, and that can release factors that drive inflammation. There's also evidence that it what we call imprints the cells with a different phenotype, a different cell type. So what we know with obesity is that it's not just about weight, it's about the metabolic effects. And that can make our bodies more inflammatory in terms of the cells and tissues.
Okay, thank you. Another question, patients that are taking these drugs, they feel full, so they are not eating much. Doesn't that affect their body hair loss and feel tired and so forth?
I haven't seen data on hair loss. There are, I mean, the other question referred to about side effects. One of the things we are looking into, and many people are doing the same, is reports about other tissues you do want to maintain, one of which is muscle mass, and that's a big area for us to be what we're working on in Birmingham, trying to maintain healthy muscle mass as we get older. So there are things we need to be considering. I hadn't heard about the hair loss. I mean, I might want to avoid taking it. I've lost enough hair already, I think. So yeah, I think if hair loss is a concern, then yeah, certainly one to consider.
Okay, Thank you. We've got lots of questions coming in now. Let's see how many we can get through. We have one which is about rheumatoid arthritis. So could these drugs also help the inflammation caused by rheumatoid arthritis?
I think they probably could. We've not looked at that. And I think the focus, because it's been considered to be an indirect effect of the weight and that strong relationship between obesity and osteoarthritis, most of the studies have been in those patients. But I think the fact we're seeing those fibroblast cells become less inflammatory, then I would expect we may well see the same in patients with rheumatoid arthritis.
Okay, that's positive. Are this cohort of patients to remain on these drugs lifelong?
That's a good question. Yeah, we don't have the answer for that. So those clinical studies have been run for 2 years, and it shows that the weight loss is maintained whilst people stay on the drugs. Big question is, as you said, how long should patients stay on these drugs, and what happens when they come off the drugs? And I think that's important. How are we actually changing people's lifestyles here enough, or is it going to be a case of come off the drugs, and if they eat unhealthily again, don't stay physically active, will they regain the weight? That's going to be really important to consider. But as far as how long they should be on, we don't know. We don't know longer term will some other side effects emerge. And one I mentioned was the muscle mass declines, which may become important as we move forward.
Okay. This is a really interesting one. Somebody's asked if the drugs are prescribed to normal weight patients as treatment for OA, would it also cause them to lose weight and make them underweight? If so, what are the safety concerns with this, and how are the risks, harm, and benefits weighed to ensure patient benefit?
Yeah, I mean, that's a really good question. We don't have the answer because they've only been prescribed on the basis of being overweight or obese. What happens if someone who's not in that category, who's normal weight, takes the drugs? We don't know. If we look at the clinical trial data with patients with obesity and overweight, what you can see is when they carry on for 2 years, it actually plateaus after about 60 weeks. So it does seem in those studies that it does reach a point of weight loss where they become normal weight. And even if they carry on taking the drug, they don't carry on losing weight. They maintain a healthy weight. So that would be a good sign that we would expect to see perhaps with normal weight, you don't actually lose any further weight.
Okay, that's encouraging. Another really interesting one. If the symptoms of osteoarthritis increase with age, even if they take the drug, will this still be inevitable?
Yeah, yes. I think it's going to be a lot for a drug to do to completely reverse osteoarthritis because as in many conditions, there's multiple factors at play here. So the study with the cartilage loss over time, over 5 years, in patients with that drug, there was still a reduction in cartilage over time. And what we know, once you've lost cartilage, it's very, very difficult to get cartilage to grow back again. So I think at best, these drugs are going to slow progression and delay progression. And in some patients, that will be really important. It might mean they never need a joint replacement, or they just get reduced pain and better quality of life over that whole period. So that's really, really important. But we don't know whether they're going to completely stop osteoarthritis. And we don't have any drugs at all that can do that at the moment. So we're often just treating osteoarthritis with pain relief medications. And of course, ultimately, patients will then progress. A lot of them will progress and need total joint to be replaced.
Okay, thank you. Another question we have is, well, let me know if this isn't one that's perhaps suitable for you, Simon, but do you find the use of wear and tear and bone on bone negatively affects patients' ability to think there's any point to change their lifestyle?
Yeah, I think that's a very, very good question. I think I would agree with that. I think we've been hampered as researchers and a population of people with osteoarthritis and researchers working together for many years with these labels because I think it has had a big effect on our understanding and the drive to treat it. This inevitability that's labelled there with wear and tear, it does give that impression we can't change the cause. But the fact we're showing now actually there's inflammation going on there. We've got drugs treated for, you used to treat rheumatoid arthritis patients that treat inflammation. It may be that some of those could benefit patients with osteoarthritis, but we haven't really tested those properly because with these labels. So I think that's really important. And I think it's important we correct that. When we hear people say non-inflammatory wear and tear, we need to push back on that.
Yeah, okay. And actually, just sort of linking on from what you said, one of the questions is, what effective anti-inflammatory treatments are there as alternatives to weight loss drugs? I presume that means specifically for osteoarthritis, because we know there are lots of drugs for things like rheumatoid arthritis, but
Yeah, yeah. So there are ones we use. I mean, mostly about relieving pain rather than changing the disease course. So patients will often be, we'll take ibuprofen, that's an NSAID, that will be anti-inflammatory, and they'll get pain relief from that. So it's reducing the symptoms, but it won't improve the change and progress. It won't change the rate at which you would progress. The other option is steroid injections. Those are used often for patients with knee and hip osteoarthritis, where they inject directly into the joint some steroid, and that will be anti-inflammatory. So again, patients would experience some pain relief there. But it tends to be short-lived. That's one of the problems. It would be maybe a benefit for a few months, and many patients might then want to come back and have a second injection. And that generally that's not repeated, so they might have 2 injections, but not a third injection. There's always a risk with those injections. You might cause some longer-term damage with repeated injections. So what we treat at the moment is the symptoms of anti-inflammatories rather than modifying disease. But that's not to say that other existing drugs that we currently use for other patient populations might be repurposed. That's something that I think would be an area that we're interested in researching, whether we could repurpose existing drugs for patients with OA.
okay. Right, we're getting lots of other questions still coming through. Let's see what else we've got. This could be an interesting one. What are some of the ethical issues that arose with taking the drug? And they've also said, how would you regulate the use of the drug?
Yeah, that's a good one. I mean, it is an issue at the moment because, of course, we know that a lot of these drugs, people can actually access some of these online rather than going through their GP and their doctors. So I would advise anyone not to do that and to talk to their clinician. And they are meant to be prescribed for people with overweight and obesity at the moment. So despite we're seeing these indications of benefits perhaps elsewhere, at the moment we're not prescribing it for those patient populations. So ethically, talk to your GP who can actually assess holistically a personal situation in terms of characteristics and any perhaps confounding factors, who will then make a decision whether it's appropriate.
Okay. Question about well, the person has asked with if I think that what they're trying to say is if a patient has gallbladder removed, would you still be able to prescribe the drugs when the primary goal is not weight loss but targeting the inflammation? That one you can answer.
I think that's a tricky one to answer because, yeah, I think you'd have to ask that for your clinician to assess, really. Yeah.
Okie doke. What else have we got here? There's a few questions about the safety of the drugs. I suppose we can group those together just in terms of, is it too early to know how safe the drugs are, sort of long term yet?
Longer term, I think it is because, as I said, most of the control clinical trials, and that's really what we need to look at, have run for a couple of years. Now, in those trials, they're seeing mostly the gastrointestinal side effects. So those have been mild to moderate, so they're not severe in most cases. And some of those side effects were seen in patients on placebo. So that's great news. But what we don't know is what happens over a much longer period. If people are going to take these for 5-10 years, is it possible that some things would emerge? It is possible, we just don't know. I think the muscle mass is important. Muscle is so important to maintain function as we get older. It helps us reduce frailty as we become older, maintain healthy muscle mass. Now, there is data that as the body weight decreases and the fat mass reduces, there is also a decline in muscle mass. Not as much of a decline as we see in the fat mass, so that's great. But ideally, we don't want any muscle mass decline. Now, that could be improved as we understand that better. What about if we maintain good physical activity levels with these drugs so we can maybe combat some of that decline? So these things need to be looked at. But at the moment, I think there's nothing too alarming. It's just what happens if people take these over a much long period. We don't have the answer for that.
Okay. There's another question linked to side effects, and it's asking, is there any evidence that a side effect of the weight loss injection causes kidney stones? If you know the answer to that one.
I don't know. I haven't seen data on that, but I want to rule it out. Could be evidence of that. I haven't seen it.
Okie doke. We have, what is the efficacy of the drug in OA? Oh, is the efficacy of the drug in OA dependent on the dose of the drug?
I don't think it is. In terms of the clinical trials have shown efficacy at both doses that are being used, I've seen. But clearly there'll be a point where it becomes less efficacious. And I know the way it's prescribed at the moment, people tend to take a dose and then it escalates up. So what's important to remember is when people entered these clinical trial for OA, those were patients with obesity. So they would have been on fairly high doses, what you'd be prescribing for people who are without osteoarthritis, who are obese. They'd be on those higher doses. Now, when you taper that down to very, very low doses, then you probably would lose some efficacy. But in those clinical trials, they were just comparing the higher doses, and there wasn't a difference in efficacy there.
Okay. Few more to get through. So we have a question asking, can damaged or depleted cartilage regenerate?
I'm going to say no there. I mean, there are studies that show evidence of that in some of the animal models, which we don't do. And there are companies that will promise stem cell therapies that will regrow cartilage. It's very, very challenging to do. There are groups in the UK who are doing surgical implantation where they'll take cartilage from the nose and other areas and then actually grow the cells up and then reimplant them into the cartilage to try and fill defects. There's a little bit of evidence that might work, but on the whole, when you lose a lot of cartilage, it becomes very, very difficult to actually regrow that back.
Okay. There's a question here that says, why can inflammation in the hands only affect one hand?
Yeah, that's a brilliant question. We don't have the answer to that. I think it's most likely it comes back to the fact that osteoarthritis is probably caused by multiple factors in combination. So we see patients all the time with perhaps OA in a hip and the other hip's fine, but some patients will have it in both hips. Some patients have a hip affected and a hand affected. So there must be a common factor, and I think the inflammation is a factor, but it probably needs to be combined with something else. It could be at some point there may have been a minor injury to the joint. It could be something else that's happened. But that combination of factors then means that joint is maybe susceptible. And then with inflammation, then the two factors combined drive the osteoarthritis in that hand and the other hand's okay.
Okay. So we're still getting lots of questions coming in. So we've got a few more minutes. So a question here about types of food. So some foods are known to be inflammatory. So is a change in diet in those taking the drugs, would it have an effect?
I don't think it's been looked at in terms of combination with the weight loss drugs, but it's a really good question. We know that diet does affect inflammation. There's lots of information out there about anti-inflammatory diets used not just for patients with OA, but in general, trying to reduce inflammation. Patients with multiple sclerosis have seen benefits following anti-inflammatory diets. So I think it's a really good question. I don't think it's been looked at in combination with the weight loss drugs, but certainly would be interested to look at.
Okay. I'm going to attempt to ask this question now, but I may pronounce this wrong, so apologies in advance. What about the risk of medullary thyroid carcinoma linked to GLP-1 agonists?
Oh, I don't know anything about that. I have to pass on that one, I'm afraid.
Okay, no worries.
Yeah, pass.
Okey-doke. And then we've got, what type of stem cells might be needed to treat osteoarthritis?
Well, there's mesenchymal stem cells, and you've got stem cells we can generate from cartilage tissue. And those would be the best type because we can then uh, turn them into chondrocyte cells that will make good quality cartilage. We can do these things quite well in the laboratory. The challenge is when we want to transfer that back into patients, and we have to be really careful there we don't provoke an immune response to the joint as we do that. So those are the challenges there. So quite often things will work well when we culture cells in the laboratory, but send that transfer into patients. That's the real challenge.
Okey-doke. This is another one sort of linked. So I think we had a sort of similar question earlier on. But if people followed a strict weight loss program that offered the same weight loss results as those on the weight loss drugs, would they still have the same anti-inflammatory benefits of those on the drugs, and
We
therefore
don't.
improving
Yeah,
their
that's a good question. I don't think they would, but it's a good question because as we see from the clinical trial data, the diets were the same between the placebo and the weight loss drug, but the weight loss was greater with the drug. But what happens if you follow a diet that will give you the same amount of weight loss? Would you see the benefits? We don't know, but I think what we're seeing from our data is that these drugs directly affect the cells. So that's different. And I think we're going to see additional benefit there from those drugs directly impacting the cell activity, independent of the weight loss.
Okay. Might have time just for one or two more questions. Can these drugs help with osteoarthritis once it's been present for quite a while, or is it more of a preventative or early stage solution?
Yeah, I think it's going to be better as a preventative. I think because as the other question was asking about the cartilage, can it be regrown? When that cartilage is lost, I think that's really hard to reverse that. So ideally, what we need to do is actually use largely preventative. So when patients got early stage disease, the joint's inflamed, but perhaps the cartilage damage isn't too progressive, and intervene at that point. That's not to say we won't see some benefits in terms of perhaps improving a bit of joint pain later on in the disease, but primarily I think the biggest benefit is going to be early stage, really trying to slow and change the disease course.
Okay. And I think this might have to be our last question now. I hope you can answer this one. It says, can genetic modification be used instead of drugs for treating osteoarthritis?
No, I think that's unlikely. I mean, there are drugs that we're trying to develop, similar to how these weight loss drugs work that will directly affect cells. But I think genetic modification is a challenging route for human therapies.
Okay. Okay, right. I think we're getting towards the end of our time. So just want to say thank you very much to you, Simon, for an excellent talk. Great to see so many questions coming through. Sorry to those that we haven't been able to answer them live, but we hope you've all enjoyed it and found it interesting. I just wanted to mention a few things before we finish. So if you have enjoyed tonight's talk and you think you might be interested in getting involved in research yourself, there are a number of ways that you can do this. You might want to take part in a study or a clinical trial, and there's a national website you can register with, which will show you all the different studies that are available to you. And my colleague Becky's going to put that link in the chat for you now, and that's called Be Part of Research, which is the slide you can see on the screen at the moment. And as I say, that's a kind of an online national register. You can get notified about different studies that might be of relevance to you. So that's one way. The other way, well, to say this webinar series has been a result of us working directly with some of our really amazing public research partners who, we really thank for their time and contributions. And at our research centre, we involve and we engage with lots of public members and local communities in different ways. And we're always looking for new people to join. So if you have lived experience of one of the conditions that we do research into, it's really important that we get the public voice and get people involved in our research, and it can make a real difference to our research outcomes. And there's lots of different ways that you can get involved to suit your own preferences and your own commitments. If you'd like to find out a bit more about that, Becky's going to pop another link in the chat, which is an online form you can complete to sort of express your interest in getting involved in some of the research that we do. And if you want to read a bit more about the type of ways you can get involved in research, you can go onto the BRC website. If you look at the patient and public involvement section, it'll give you some examples and information about getting involved in research. And so I think that's it for this evening. So thank you very much to everyone for joining. Really hope to see you at our next talk in April. And do we have our next slide? Yes, we've got our next talk. I've just put that back up on the slides. It's going to be a really interesting talk generally about research, what it is, and why it's so important that we do it. And that's with Dr. Joe Lunario. So we hope you'll be able to join us on the 16th of April, 6 till 7 again. You can hopefully find the link in the chat, which Becky will post for us in a minute if you want to sign up for that event. And finally, if you would like to, we'd love to get some feedback from this evening's talk. So we will be sending out a feedback form. Again, I think Becky's popping it in the chat, but we'll send it to you on email afterwards as well. If you could fill in the feedback form, that would be great, because it just always helps us to improve our sessions going forwards. It literally only takes a few minutes, but it's really helpful for us to kind of improve what we do. So yeah, so that just leaves me to finally thank Simon again. Hope you've all enjoyed it and hope you have a nice evening, and we look forward to seeing you again at our next talk. Thanks very much.
Thanks, everyone.